Good afternoon. I would like to thank organizers for this opportunity. I'll be presenting this paper on outcomes of radiation therapy plus immunotherapy in metastatic renal cell carcinoma, results from Canadian Kidney Cancer Information System. It was published in 2022 in Advances in Radiation Oncology by Eric Nguyen et al. Coming to the background of this article, immunotherapy is the first-line option for the management of metastatic renal cell carcinoma, and evidence has suggested that response to immunotherapy may be potentiated by radiation therapy due to the synergistic potential of combined modality therapy. Compared to conventional fractionation, stereotactic radiotherapy with high-dose radiation may produce immunomodulatory effects which enhance immunotherapy response and overcome radioresistance. It has been hypothesized that higher dose of radiation initiates endothelial cell apoptosis, which results in excellent local control, but this is not seen in conventional fractionation. So, purpose of this study was to evaluate outcomes in patients with metastatic renal cell carcinoma receiving immunotherapy and radiation therapy compared to immunotherapy alone. So, data were collected retrospectively from 14 academic centers across Canada between January 2011 to September 2019. In total, 505 patients with metastatic renal cell carcinoma who received immunotherapy either as first line or second line were included. And the patients who received radiotherapy 1 month prior to initiation of immunotherapy and during the course of immunotherapy are grouped into combined modality arm. And the patients who have not received radiation during immunotherapy are grouped into immunotherapy alone arm. So, among patients who received radiation therapy, radiation is categorized into either radical RT or palliative RT. So, RT is considered radical if dose is more than 10 gray or equal to 10 gray for single fraction treatments, or for multiple fraction treatments if the fraction size is more than or equal to 5 gray, or in total bed, that is biological effective dose, is close to or more than 40 gray. And the common immunotherapy regimen was PD-1 inhibitor plus CTLA-4 inhibitor. Endpoints for overall survival and time to treatment failure. When we looked into the patient and disease characteristics, so there was no, it was well matched in two groups with respect to nephrectomy, histology and performance status. However, patients in radiotherapy arm had a significant bone and brain metastasis, and also the patient had a second line therapy which was significant in patients who received radiotherapy. Among radiotherapy group, you can see only 1/4 of the patient received radical RT and remaining 3/4 received palliative RT. And among radical RT, the common fractionation was 30 gray in 5 fractions, and in palliative RT, it is 8 gray in single fractions. You can see there is no uniformity in either radical or palliative RT. And most of these patients received radiation after 3 months of initiation of immunotherapy. When they looked at the results with a median follow-up of 13.9 months, 2-year overall survival was around 55 in a combined arm, and it was 66 in a immunotherapy alone arm. Though outcomes were favorable, but did not reach the statistical significance. However, time to treatment failure at 2 years was 12.2% in immunotherapy, combined arm, and it was 30.9% in immunotherapy alone arm, which was significant. When they assessed outcomes between radical and palliative RT, there was no difference either in overall survival or time to treatment failure. Similarly, when they assessed outcomes based on the line of systemic immunotherapy, if patient received first line immunotherapy, there was no difference in the 2-year overall survival. However, time to treatment failure at 2 years was slightly significant. It was significant in immunotherapy alone arm. However, if they received second line chemotherapy, there was no difference at all either in 2-year overall survival or time to treatment failure. So the conclusion was overall survival and time to treatment failure of the combined arm were less favorable compared to immunotherapy alone cohort. The clinician should be cautious in selecting patients for combined modality therapy based on performance status and metastatic burden, and more research and prospective data is needed with the focus on RT timing and clarifying appropriate dose fractionation based on immunotherapy agent. So my take, there's a significant heterogeneity in patient population and also in prescribing RT dose. more than 90% of the patients in radiotherapy arm had brain and bone metastasis, which was poor prognostic factors. And nearly three-fourths of the patient had received palliative radiation with the primary intent of symptom relief, that is purely palliation rather than local control. And majority of them received very low RT doses. Optimal dose and fractionation, it has not been defined yet, but however, preclinical studies suggest that dose as low as 12 gray per fraction is needed to initiate immunomodulatory effect. And finally, there is no data regarding the metastatic disease status, whether it is synchronous or metachronous, whether low metastatic burden, high metastatic burden. If they had selected patients properly, then RT radiation may have shown significant benefit, especially with oligometastasis or oligoprogressive disease. Thank you.